Folks, it's RLR today, and Prof. Rez would be very, very happy to tell you that his able substitute, Rahul, has more than earned his space here. Rahul has been part of CP Solvers for, it feels like a decade, but several years now, in his second year now. And he will tell you humbly that he's an intern and he's working really hard, but I think don't let his humility and his gentle demeanor fool you. He's a clinical reasoning monster with a ferocious appetite and incredible work ethic. And I'm very excited to celebrate that. As you all know, we kind of use Prof. Rez's platform, which he graces once a month to remind us of his impact, but also steps aside to allow people who are legends in the space to continue to have the opportunity to learn and grow. And so very, very excited to finally co-discuss with you. It's been a while. I know it's really hard to co-discuss with any intern. So I'll hand you the mic to say hello, and then we'll introduce everybody else who's spending some time with us today.
Thank you so much, Rabih. Rabih, can you hear me?
Yes.
Yeah, yeah. So thank you so much for your kind words. I think I remember it was I think back in 2023, 24, I joined the CPS, and the way the CPS molded me, a kind of doctor I am today, I completely owe to the CPS and to you. And I remember, I think it was March 13th, Thursday, 2025, before 1 week before the match. We co-discussed together for the first time for the Marks case. And today again I'm feeling the same feeling of nervousness and the equally excitement to learn from all of you. It's been great journey so far. And yeah, I'm very, very looking forward for Lira's case. Yeah, thank you so much everyone for joining today.
Very, very excited to do this again and again and again, my friend. We have a lot of people to thank. First, Siva for scribing. Siva, I'll hand the mic to you. Maybe you can update people on how you're doing.
Hi everybody, I'm Shiva. I'm currently based in Buffalo. I'm really excited for the case discussion today because it's like uh, the group is really the group that we look up to actually.
I see that you're in the lab right now, I think. Is that right? Or somewhere else? Yeah.
Yeah, that's right. Yeah.
Yeah, thank you for joining us. And in the teaching points, lukewarm seat is Manaswini. Mic to you, Manaswini.
Hello everyone. I'm really excited to be doing teaching points for a session where my dearest friends and the superstars of CPS are co-discussing and presenting as well. So excited.
Oh, that's very, very kind. I think that the spotlight goes right back to you with that label for sure. But I think it applies to both Rahul and Lyra, who is presenting. Mic to you, Lyra.
Yeah, hi everyone. I'm super excited for the session. It's going to be my second time presenting the case to Rahul. First time he crushed it, so I wouldn't expect nothing less from this one too.
Indeed. All right, let's rock and roll.
Okay, so for the chief complaint we have, this is going to be a story of a 62-year-old man that presented with progressive lower extremity weakness. And just to get you a sense of what it looks like, so his symptoms started over 1 year ago. And at baseline, he was actually quite active. So at first, he noticed that he had unusual for him difficulty climbing stairs up to the point that after a few months, he needed to pull himself up using the handrails. And around 9 months later, he was no longer able to get out of chair without using his arms to push himself up to stand. And at this point of time, when he presents, he now requires crutches to walk or actually even uses a wheelchair to do so. And otherwise, on review of systems, he also endorses some episodic muscle cramps and some degree of unintentional weight loss. So what do you think? And another question to you is, what would you be curious about to know also on the review of systems for this patient?
All right, Rahul, what are you thinking?
Right, really, really interesting chief concern for which we commonly see in the hospital, especially with the elderly age people. It's really interesting that here I'm seeing a very dynamic disease process that all of a sudden it started 1 year back. The acuity is kind of chronic and initially started with the difficulty climbing. I'm assuming that maybe the patient could have some issues with his simple activities of daily living. Now it reached to a point where he has to use some kind of assistance to get with his life. So keeping that aside, now I know what exactly is baseline. Now can compare how destructive the disease process is. So now how can I make the progress here with the lower extremity weakness? That its weakness is some kind of very non-specific thing, but we have some kind of anatomical structures which help us in walk around. So what are the structures we have? We have the spinal cord, most likely the lumbar and sacral spinal cord. We have all the muscles and the bone, and that all the structures need the stimulus, like in terms of nerve. And more than that, it also requires some kind of nutrition in terms of vascular supply. So, how I'm going to achieve the progress here is that I'm going to question, is this something to do with the claudication? Because most of the people with the vascular claudication, they're going to have the lower extremity, maybe I can call it as angina, where they're going to have some decreased blood supply. They can take some time to walk, something like that. So, something like arterial issue. And the second thing would be, am I dealing with any sinister cause of proximal muscle weakness? Because the patient now, he's having difficulty climbing stairs, for which the patient has to require the use of gluteal muscles and thigh muscles. So that really makes me worry about, am I dealing with any kind of muscular process? And the other thing would be, as I said, maybe some neurological involvement, because given the 62, I really want to know what exactly the patient occupation was. Maybe that really required some kind of very load on the spinal vertebral column in terms of causing the spinal stenosis. Is it something getting very progressive destructing process, compressing the lumbar spine, all the spinal nerves which are exiting from the foramen? So this is something I'm interested. At the same time, we are seeing here an unintentional weight loss. Is it related to that? I don't know if the patient has some issues with the pharyngeal muscles or all these muscles of deglutation. I could think about it, but the patient is not complaining of anything. But anyways, I have to ask my patient, hey, how is your diet looking like? Do you have access to food? And do you have any dysphagia or odynophagia or any other GI symptoms? Then I can invest more with his unintentional weight loss. So right now the problem is kind of multi-system, I would say, but still I have to understand what's going on with this patient to make some diagnostic progress. What do you think, Rabi?
Yeah, I'm right there with you, Rahul. I think that on the surface of this case, it can be very easy um, to think that the problem is actually very small, meaning that it is a subacute, severely progressive, isolated proximal muscle disease. And if you just take the words that Leora shared with us at face value, you have strong reason to believe it's proximal muscle for reasons you already explained. You have reason to believe that it's subacute and severely progressive because of how debilitated the patient is. And then you hear some painful component to the disease process. And then it's kind of silent, except the weight loss. But it's very easy to see how somebody who is struggling to get around and barely able to function may not have the energy impetus to eat. And so if you take it at face value, the nature of the problem seems to be really, really narrow. Not many things that cause such severe, profound muscle disease, especially when it's restricted to the muscle. So I will not share the specific diagnosis that is coming into my mind out loud with you all because I think that it is a massive bias. But I will tell you, if you represent this problem as a subacute, devastating, progressive, isolated, lower extremity, proximal, predominant, painful muscle disease, which is all accurate right now, there's actually only one possible diagnosis. But I love this aliquot because it's very likely when you're talking to a patient that you have misrepresented the problem. It's too soon to confidently call it that. And what am I doing? I'm doing exactly what you're doing. I'm making sure that there is no other neurological localization. And I think you have to take careful inventory of any other organ involvement. And I think that the problem with doing so may be really captured under the realm of the camouflage effect, which is fundamentally when somebody has something so severe, like horrific epistaxis gushing out of their nose, that they may forget to tell you that they have abdominal pain from an expanding AAA. And so I admire your caution. It's tempting to think we know what the problem is, but because how severe the initially described problem is, there may be threads that for us to see that the patient may have understandably ignored or minimized or adjusted to or felt less important than how severe this muscle disease seems to be. So don't be tempted to represent this problem narrowly. We have some work to do, as you just said. All right, Leora, mic to you.
Yeah, I haven't done this in such a long time, so I forgot to say that the case is going to be consisted of 6 aliquots with the final aliquot revealing the final diagnosis. So additionally, on review of systems, he didn't notice any fever, no night sweats, and no loss of appetite. He didn't also notice any chest pain or shortness of breath or edema anywhere. There was also no abdominal pain, no nausea or vomiting. He also denies, a great point that Rahul made, he also denies dysphagia or odynophagia. And he didn't notice any rashes, arthralgias, or myalgias. So no leg pain per se, as Rahul was also mentioning. And he also denied any numbness or tingling. And there were no change in bowel movements and no bladder symptoms. So a little bit more history about the patient. In the past medical history, he also has hypertension that is well controlled on amlodipine. He also has hyperlipidemia that is controlled on atorvastatin he's been taking for many years now, and ezetimibe that was added last year. He also has BPH, which is controlled on dutasteride, and some history of chronic back pain. There was no relevant social history. His job didn't require any increased physical load on the spine, as Rahul was asking. And there are no family history of similar symptoms. So with this complaint in mind, he had some workup done in the outpatient setting. And in the EMR, there were no physical and exam information recorded, but the lab testing revealed, basically it was unremarkable. So they checked his blood count, so white blood cell count was normal at 6.7, with normal differential 65% neutrophils and 27% lymphocytes. His hemoglobin was also stable at 15 with MCU of 88. His platelets were also normal at the rate of 274. So for the metabolic panel, for his electrolytes, everything was normal. His sodium was 144. His potassium was 4.8. His glucose was 95. For his liver function, his ALT was mildly increased at 60. AST was normal at 32. His alkaline phosphatase was 84, which was normal, and total bilirubin was also normal at 0.84. So for his renal function test, his creatinine was 0.56, which was actually on my EMR highlighted blue because it was lower than expected. And his BUN was normal at 17.6. And there was also AUA that was largely unremarkable except for some trace protein present. And that's it for the cell code.
Interesting. All right, Rahul, what are you thinking?
Yeah, thank you so much, Lira, for giving some of the other data to make some progress here. I mean, honestly, Rabi, with these given review of systems were negative, that at least that reassuring me that, let's say, maybe let me put in this context, if the patient was complaining of some short of breath or some exertional problem, then I would have worried more about the diaphragmic problem. But here, given the complete, I would say, review of systems negative, that at least makes me feel comfortable. Maybe the disease process is not affecting systemically, maybe more concentrated on the lower extremity, something like that. And given the before we think about any process, I'm always wonder, are there any, as you taught us before multiple times, are there any other external substances which could potentially cause any other disease involvement? Like here, I'm seeing atorvastatin. I'm not going and say, hey, this patient is having some necrotizing myopathy due to atorvastatin, but something I keep in back of my mind. But though the patient has been taking from the long period of time, but the studies say that people still end up having the statin mediated myopathy or necrotizing myopathy, something like that. And now the prostate problem, I'm assuming that dutasteride, it's cousin of finasteride, it's for the prostate issues, and patient here is complaining of back pain. Now, what I'm gonna ask to my patient, hey, any now I don't know if I have to clearly invest my lot of time with the back pain, but given the prostate with the elderly individual greater than 50, what I'm gonna do is I will keep in my back of my mind regarding the prostate issues as well, because the prostate cancer is one of the emerging thing. And maybe I can check in the primary PCP's office. Did it ever get any PCA as a screening modality? Because the prostate can compress on the, I think it's gonna go into the spinal cord involvement, and it can infiltrate the bones, can cause back pain as well. So something. Now this is something where the patient does not have any fevers, and I really want to know if the patient has any kind of cord or cauda problem. But Lira clearly mentioned that the patient does not have great review of systems. So this is something I can consider. And I don't have vitals here. So would you want me to talk about the labs, or do you want to take over?
No, I think that ultimately progress you're making, Rahul, is there doesn't seem to be any extra neurological features to grab onto, both in terms of the symptoms and the labs, which are essentially unremarkable, right? And so I think it just goes to show you that the progress you're making is that you're listening and listening and listening and listening, and the patient nor his prior evaluations are telling you aren't telling you anything, but the fact that this disease seems to be restricted just to this area. And I think just like your case yesterday, when you're trying to understand the nature of the problem and trying to figure out, is it localized or is there more to it? Ultimately, this is where your eyes will be so key. And when we examine this patient, I can't, I can predict, my sense says that this case will only be given momentum towards a diagnosis once you examine the patient and really understand, is this disease really restricted to this area, or does he have a rash? Does he have abdominal distension? Does he have reflexes? So far, it seems to be that that hunch that this is a very tight problem is bearing fruit. But I wouldn't be surprised if there's a AAA on exam again today, because I think you have to be open to that possibility. All right, Lyra, Mike, to you. What do you have next?
Such a great thought. So yeah, and it actually, the case will show you exactly what you just said. So as everyone in the chat was asking, due to the symptoms of weakness, CK was also automatically sent by his PCP, and it came back elevated at 360. So with the combination of these findings, he was referred to rheumatology due to concern for myositis. And this is when I met him a few months after during my rheumatology rotation. So as it usually is in our wards, information about the patient in the EMR is available faster than the patient itself. So you open the EMR and see that the labs at the time of admission, including CBC, liver function test, and renal function test, remain largely unchanged. So there is still mild transaminitis with the same proportions. There is still lowish creatinine. And his CK at admission remained elevated at around 300. with upper limit of normal in our lab being around 190. Additional basic testing on admission included calcium that was normal at 9.8. Uric acid was also normal at 5.7. TSH was also normal at 2.1. And total protein was 7.2 and albumin was 4.4. His ESR was 7 and his CRP was 1. LDH was also normal at the level of 370, with the upper limit of normal in our lab being 450. He also did some ID screening, so his RPR was negative. His HIV as well as hepatitis panel were also negative, and some basic imaging. So the chest X-ray was available and it was unremarkable. EKG showed just a sinus rhythm with the heart rate of 74 and some left ventricular fascicular block. Echo was also done just before the admission, so his ejection fraction was good at 68%. There were no formal left ventricular hypertrophy described, but some diastolic dysfunction noted, no focal wall motion abnormalities or valvular issues, and no evidence of pulmonary hypertension. And I was there.
The intrigue continues, Rahul. Oh my gosh. Okay, what happened to your thinking now?
I mean, Lira, if you, I mean, are you going to, I mean, I don't want to disturb your flow here. Do you want to give the physical examination findings later?
I think she's intentionally setting you up for in her world where she got the information before she saw the patient. I think the setup here is very intriguing. I know you want the exam, but the truth is that in true EMR, just like you probably do, you first look at the chart, then you examine. So what are you what are you thinking?
All right. So now, I mean, without having a physical examination
Yeah,
findings, I really don't want to
yeah,
represent the problem, but
yeah,
at
good.
least I can comment on the labs.
Can I don't mean to interrupt you, but I think that that's the most powerful learning point. Maybe you can just expand on why you're having this friction. Because I think people will learn a lot from why you're reluctant to name the problem. What is it about it that is giving you difficulty?
I mean, still the all the chief concern and some of the labs were thinking me to incline towards the muscle,
Yeah,
but without having, and I
right,
know subjectively that it's so severe, so destructive that patient is using some kind of assistance,
right,
but I need some objective data using maybe power,
right,
reflexes,
right,
and the gait,
right,
all the new bulk of the muscle. It's
right.
going to tell me what's going on with the muscle itself. So
Good,
that's why I'm having kind of friction here
good,
to represent the problem. But
great.
anyways, as Lira, I don't want to disturb the Lira's plan.
Yeah,
I
yeah,
want to comment on
yeah,
the labs.
yeah.
So it's really interesting, Ravi. I'm seeing creatinine of 0.56. I mean, I don't know if something is related to this case, but often these values we see in very elderly individuals with 70s or 80s or 90s. I had a patient with 106-year-old female where her creatinine was zero point 0.9, but she has AKI. It's because her baseline creatinine is zero point 0.4, because creatinine is mass produced from muscle creatine, right? But having said that, do I really expect low muscle mass with a 62-year-old male? It's possible, but this patient is completely fine, 1 year back, not bed bound. So kind of, I don't know, but something, maybe the muscles are getting very atrophied, something to consider. And other labs, Lila, I don't know if the ALT is highlighted here. Do you think the 60 is kind of abnormal in your lab? The ALT
Yeah,
of
yeah,
60?
yeah, it's
All right.
higher than
Yeah. So now I'm seeing an AST of 32. Is AST also abnormal or normal in your lab?
HT is normal.
Perfect. And now I'm seeing an ALT of 60 and AST of 32. Again, it reflect going back. Is it something in a muscle? Because in patients with muscle injury with myopathies, they're gonna have high AST to ALT ratio, same like alcohol liver disease. But in patients who have, again, this is coming from your own wisdom, Rabi, that in patients with chronic muscle disease, I think the ratio will be reversed. The ALT will be greater than AST because the AST has got very short half-life. Again, it's telling me, hey, look into the muscles. And
Uh,
then CK, if I'm gonna go for a run, as you did in the morning, if I'm gonna check your CK, it's going to be 500. But it's unethical to call it you have some kind of myopathy. So I don't want to jump in and say, comment on the creatinine. And other substance like thyroid is fine, but I never saw any patient with thyroid induced myopathy. But other labs did not give me much thing. But the creatinine, low creatinine,
mm,
and the high ALT is
mm,
gonna give me, hey, look in the muscles.
yeah,
More likely, just to be make sure that I'm not dealing with any kind of hepatocellular pathology. I
right,
want to get a GGT just to be kind of comfortable that I'm only dealing with the MSK process,
very
not
good,
the all the hepatocellular pathology.
very
So
good,
that's what I want
very,
to do, Rabi.
very good, excellent, absolutely outstanding. I think you're teaching us how diseases evolve over time and how we're trained to pick up entities in their initial angry form. And somebody who is presenting perhaps in a delayed manner may have a different laboratory signature. The level of troponin in somebody who had a massive myocardial infarction depends on when they come to see you. If they have Q waves on their EKG, their troponin may not be very high. But if they have ST elevations on their EKG, their troponin will likely be very high. This patient is coming in almost a year after his symptoms, and it's very plausible that his muscle troponin is not very high anymore, and so you have to look for Q waves. How do you find the Q waves? You see that he has low muscle mass as inferred by his creatinine. You see that instead of an AST predominance, he has an ALT predominance. These are very, very subtle features that this person may not have much muscle mass and might have long-standing muscle disease. There's also another interesting paradox, which is how can you lose this much weight and have a normal albumin? And that's a very, very interesting thing. It tells you that the amount of inflammation this patient has driving his weight loss is very minimal. And that if he has ongoing weight loss, the driver of it is often malnutrition or malabsorption. And so I think, as you said, it's very hard to understand how to make progress and goes to show you that tests are all obtained in the context of first your ears, then your eyes. This could mean that he had severe necrotizing myopathy and now has burnt out all his muscles, and that's why he can't walk, and that's why he has no creatinine, no CPK, and an ALT. But it also may mean that he has a completely separate issue and that he is actually horrifically depressed. And he's so depressed from life circumstances and is showing up in a way that is localized to the legs, in large part because the legs are what he needs to move. So you cannot diagnose somebody without first using your ears and then your eyes and then asking other people, such as the laboratory tech or the radiologist or the pathologist, to help you. But you shouldn't use that help before you've used your ears and then your eyes, in that order. So I really appreciate that lesson coming out now, because this person could have a million and one different possibilities. In fact, he could Lyra could say hi, and he could get out of that wheelchair and go for a jog right in front of her. That's still, oh, I'm open to that possibility, right? So we'll see. I doubt that that's true, but I'm sure that it's happened at least once before in the realm of medicine. All right, Mike, to you, Lyra.
Yeah, so this moment in the case is actually why I wanted to present to you both, because I couldn't possibly trick Rahul. So finally, the patient arrived to the wards, and you go to see him, and you walk into the patient's room and see a man that is basically comfortably lying in bed. He is quite well appearing. He is in no distress. and his vital signs are fine as well. So he's afebrile, his blood pressure is 130/75 with a heart rate of 78. His respiratory rate is 17 with SpO2 of 98% on room air. So what catches your attention instantly is how thin he looks. And there is prominently decreased muscle mass in both proximal and distal lower extremities, more so on the right rather than the left. And otherwise, his musculoskeletal exam is unremarkable. His warm and well perfused. There are pulses present throughout on upper extremities and lower extremities, and no peripheral edema and no rashes were noted. There were also no lymphadenopathy. So otherwise, his exam was also unremarkable. So his cardiovascular system was normal. No GVD, regular rate and rhythm, no murmurs, gallops, or raps. Same for pulmonary system. His lungs were clear to auscultation bilaterally without any crackles or wheezing appreciated. His abdomen was benign as well. So it was soft, non-tender, and non-distended. So then we asked for a neuroconsult to help us with the good neuro exam. So on their note, they mentioned that he was alert and oriented times 4. His cranial nerves were intact, 1 through 12. His speech was also normal, and there were no tongue fasciculations. Eye exam also looked normal. There were no nystagmus reported, and his extraocular movements were intact. His pupils were also equal round and reactive to light. As for his sensation exam, it was reported to be normal throughout. The interesting part comes with the motor exam. So his motor strength was reported to be unremarkable and graded 5 out of 5 in the upper extremities on both sides, with reportedly normal reflexes. As for his lower extremities, there was 2 out of 5 proximal extenders, weakness bilaterally, 3 out of 5 proximal flexors bilaterally, 3 out of 5 distal dorsiflexors bilaterally, and 4 out of 5 distal plantar flexors bilaterally. And as for his lower extremities, his reflexes were symmetrically decreased. I'll pause here.
Oh my gosh, this is fascinating. I think Rahul, it's the perfect time, perhaps, since we have some time, to do some breakout rooms so you can mix your thoughts with your colleagues. So why don't we reconvene in 5 minutes to analyze this exam and to see what progress we can make? Okay. All right. I'll see you all very soon. Oh my gosh, Rahul, usually like only 3 or 4 people join the breakout room. I see you were in a mega breakout room. So many people. So I'm glad you got to learn from them. What did you take away from the conversation?
I mean, I was with Jeffrey and Vale and our neurology expert,
I know.
and,
You got a
and
rheumatologist and a neurologist.
yes, so they're helping me a lot. And yeah, Vale really came up with what exactly we are dealing with here.
Yeah,
I think, Ravi, I think now it's a good time to at least come up with a summary here, problem
please.
representation to understand what exactly we're dealing. So, who is this patient? He's our 62-year-old male with history of benign prostatic hyperplasia on some bunch of atorvastatin and some other medications, presenting with chronic chronic onset of the distal lower extremity weakness with the with a pretty much unremarkable review of systems, with the examination suggestive of severe proximal and distal lower extremity, I would say the muscle, something like that, with some transaminitis, with mild raise in creatinine, with hypocreatinemia, whatever. Yeah.
I don't know, very fancy. Prof. Rez would be proud of that. That was
So,
amazing.
so those are my thoughts. So, if I was telling Lira how I'm gonna approach, how I'm gonna move further
Mm,
here, is just that now I understand the patient is very debilitated and he lost all the muscle mass, and we don't know it's because of the underlying degenerative process
mm,
slash inflammatory process, which is driving this, the atrophied, all the catastrophic muscle loss. So what I'm going to do is I'm gonna quickly check all those nutritions which are really important for the muscle, like all the vitamin B12 and folate. I'm not a fan of copper deficiency because which is more common in patients with gastric bypass, which this patient didn't have that. So those nutritional deficiency, making sure the patient has adequate nutrition to function. And the other thing would be am I dealing with any neurological component? But here the nothing is helping me in focusing on the nerve problem. But I think it's reasonable to pursue nerve conduction study, especially in the lower extremity, to look for any injury with the tibial nerve, femoral nerve. That is number two. And number three, I'm gonna hold off the statin. Even Jeffrey said, I don't know if the statin is a culprit here, but something to keep consider. And the last thing would be, the two things would be, is it something to do with the late onset dystrophies, like Beeker muscular dystrophies and limb girdle dystrophies, because we need that dystrophin protein for the muscle to function. But again, there is no significant family history here, but something to consider. And if everything is come back negative, and again, maybe because ESR and CRP is also normal, I don't know how much I have to invest about the all the inflammatory myopathies, all those spectrum of diseases. And the last thing would be, this patient did not smoke, don't have any history of smoking, but something paraneoplastic syndromes to consider in back of my mind. So this is the whole spectrum I'm thinking. So what do you think, Rabi?
I'm coming to the same conclusion as you. If you take the exam at face value, you would say that the presence of low reflexes mandates that the disease is in the peripheral nervous system. The only exception to that is when the patient has acute spinal cord disease, but that is not happening. And so now you're asking yourself, is the disease in the anterior horn, the nerve roots, the plexus, the nerves, or the muscle? And I think the proximal predominance makes you start all the way at the muscle as your prioritized differential diagnosis. But there are entities that, including certain neuropathies, plexopathies, that can present with proximal predominance. The fact that you have a laboratory signature pushes you towards muscle disease even further. And you might ask yourself, how does muscle disease reconcile with the reflexes? And so you might just discuss the paradox. The paradox is proximal predominance is muscle, but reflexes suggests something more proximal to the muscle like the nerve. And that's where you have to realize that advanced severe muscular disease causes a a drop in reflex. And in fact, what hyporeflexia really is, when we say that somebody has hyporeflexia as a clue to the nerve, is it's actually disproportional hyporeflexia. When there is drop of reflex out of proportion to the degree of weakness. We don't teach it as well. We just say, oh, low reflexes equals nerves. No, a much more impressive drop in the reflex than the degree of weakness suggests nerve disease. And the classic example is acute inflammatory demyelinating polyradiculopathy, or Guillain-Barré syndrome, where the patient may have almost intact strength, but their absent reflexes or drop reflexes are essentially confirmatory of a nerve localization. Unfortunately, this patient's weakness is so profound that that fact of disproportionate weak reflexes suggests the nerve no longer applies. And so you have to toss the reflexes, except it tells you that you're in the peripheral nervous system, but because of the profundity of the weakness, the localization value is gone. And so now you're muscle, muscle, muscle as priority, but there's so much ambiguity that an EMG is of high value. And the EMG would help you make sure that you're not solving the wrong problem. And I would prioritize a muscle problem, recognizing that you might have another problem or you might have an overlap syndrome. Features of both. And the question becomes, what causes, if you are proceeding with your assumption, what causes a devastating lower extremity predominant subacute chronic muscular disease? And frankly, it's really, I think, only three possibilities. A burnt out, completely destroyed presentation of necrotizing myopathy, which has a strong tropism for the lower extremities, inclusion body myositis, and as you said, uh, um, delayed presentations of hereditary disease. And I think since this patient is at risk for the necrotizing myopathy with the statin, that has to be the leading consideration. We don't know if a prominent family history suggests that he's at risk of hereditary disease. Inclusion body myositis is a sporadic disease, but characteristically at this stage of weakness will have finger flexor weakness. And the fact that his arms are spared and that he does not have finger flexor weakness reduces the possibility of inclusion body myositis. But ultimately, he is a patient who I would not just do a serological workup on. I think a muscle biopsy will be really, really illuminating. And so, yeah, I'm right there with you. I have the same thoughts. Um, it's amazing how a systemic disease, no matter what it is disproportionately destroying his lower extremities, sparing the rest of his body. And I think that is such a powerful tip-off to necrotizing myopathy that I'm willing to accept what I would consider, based on my exposure, a very unique manifestation of it, which is that it is completely gone to this phase. And so what that triggers me to do is to try, just like your patient yesterday, to understand why it was left to be this severe until he's finally being examined by Lyra and her colleagues. Are there any social variables, access variables that, and if I find that the answer to that is yes, then I'm more willing to accept that he had a crazy phase of high CK, a lot of pain earlier, and now is in the burnt out phase. Whew. Still a lot of work left to do. So maybe we can hand the mic to Lyra to tell us what happened next.
Yeah, you're describing the exact same tension that we had. So we were with this muscle weakness, we were also worried about the respiratory muscles of this patient. So done spirometry, which was normal and showed a good forced vital capacity. We also did some rheumatologic workup. So his RF was negative, ANA was 1 to 120, ENA and myositis panel were also sent and were negative. And we also were able to send anti-HMG co-air reductase antibodies in this patient, which is really hard to get here, and they were also negative. His complements were also normal, and his ANCAs were also negative. So we also did some minimal ID workup for endemic virus that is here, tick-borne encephalitis virus, and Lyme. IgM and IgG were negative in this patient. We also checked A1C level, and it was normal at 5.3%. Vitamin B12 level was also normal, as Rahul was asking. SPEP with immunofixation was also normal in this patient. And we also had detection of potential prostate cancer that was metastasizing. So his PSA level was sent at was 2, which is normal. And we also did CT chest, abdomen, pelvis, which was largely unremarkable except for some right kidney cysts. We were also worried about the spinal cord in this patient, so neurology advised to do MRI of the lumbar spine, which showed just mild degenerative changes in the spine, but no concern for spinal cord compression. And same was true for the MRI of the cervical spine. And the MRI head of this patient was also normal. So next, a diagnostic test was performed, which revealed the diagnosis.
No, Lyra, I just want to appreciate you for how you're presenting this case, because I think you had two options: to keep it the way you just did, or to present it in a more stereotypical manner with the exam being months sooner. But gosh, I think having the exam uh, later is a marker of realizing just how profoundly helpful it is, and how in real life medicine so many things get in the way of actually defining the problem. And so I'd love for you all to take note of Rahul saying, "Oh, I don't know what the problem is." And then he's like, "I know exactly what the problem is. And the only thing that changed is the exam." And so I encourage all of you to realize that despite the fact that the chart is available and the consultants are available, nothing will replace you talking to the patient. And I'm just so grateful for that lesson being profoundly emphasized yesterday with Rahul's abdominal exam, and today with Lyra's neurological exam. But Rahul, yeah, I'm curious, what progress have you made with this additional data?
I mean, it's good that the patient does not have this. One question, Lira, before I proceed, was the contrast, the CT and abdomen and pelvis, which was obtained with contrast or without contrast?
It was with contrast
With
and lungs
contrast.
without
So,
contrast.
yes, that's really helpful. Um, at least that's reassuring me that the patient does not have some kind of lymphadenopathy, lung mass, retroperitoneal lymphadenopathy, and even they having the normal PSA and negative osseous lesions on the spine makes me really concerning that I'm not dealing with any kind of cancerous process. Now, at the same time, as we were wondering about the myositis, along with the statin-induced necrotizing myopathies and late onset, all those syndromes, I think I learned from, I think one day Kirtan presented a case to Austin about the case of necrotizing myopathy due to statins. I think he taught me even with the negative serologist, there is still possibility of necrotizing myopathy. So if serologies are not helping me, if my pretest probability is very high, as you said, getting an EMG because EMG was not done yet, along with the muscle biopsy is a key here to understand what's going on with the muscle itself. And anything else which I can think of right now, I think muscle biopsy is going to help me. If even that, I don't know how the Beaker muscular dystrophy and all those genetic syndromes will be appear on muscle, but I have some knowledge gap there. But I think muscle biopsy and EMG is going to be helpful for you, I guess, Robbie. What do you think?
I agree. I think that there's more and more arguments to avoid muscle biopsies because of the increased value of MRI and serological testing in patients with muscle diseases. But I think for reasons we don't have time to fully elaborate on, this case is a powerful example of the yield of a muscle biopsy. I think there is some role for serological testing for the antibody that's associated, which I always forget, with inclusion body myositis, but I do want to put out the knowledge there that there's an antibody that has a high specificity but poor sensitivity or imperfect sensitivity for inclusion body myositis. I think that same differential that we outlined earlier, which is burnt out necrotizing, inclusion body, and genetic, is still at play because now you've taught us one really important thing. 50% of patients with necrotizing myopathy are seronegative, one half. And so I think ultimately, that the muscle biopsy, I think in this case will be incredibly high yield. And it's a matter of refining your pretest probability. And I think you have to acknowledge that a genetic disease can show up in this way, but it would be highly, highly unusual. And so that would be at the bottom of my list, but I would still be open to it. And I'm trying to debate how much I can push myself to adjust the pretest probability of seronegative necrotizing autoimmune myopathy versus inclusion body myositis. And the seronegative necrotizing myopathy whole or counter argument is the fact that we don't have overt evidence of the time where it was much more active. We are assuming there was a time, the assumption made is there was a time where it was much more aggressive, and we just don't know that. The assumption that we're making, or the whole and the counter argument to inclusion body myositis, is that for it to be so devastating in the legs and yet not have arm involvement or hand involvement is exceptionally unusual. And so I think each of them has one robust counter argument. Which one is a bigger counter argument? Oh gosh, I think ultimately. I would probably buy a knife, like a razor blade, be open to IBM slightly more than a burnt out necrotizing, but I would really want to talk to him and zoom in on the past to see if he gives me any hint of pain, profound weakness, changes in his urine to hint at necrotizing disease. So yeah, ultimately the biomuscle biopsy is really, really key, and I'm really curious how this case panned out, Lyra.
Yeah, I think Wally was asking this in the breakout room. So we did nerve conduction studies in EMG, And NCS basically showed that there is diffusely normal sensory nerve action potentials. And as for motor nerves, the velocities were normal. There were no conduction blocks described, but there was reduced compound muscle action potentials amplitude in both lower extremities and upper extremities on the right side. EMG showed fibrillation potentials and positive sharp waves in the lower extremities on the right side, and fasciculation potentials in the proximal muscles on the right upper extremity. And there was reduced recruitment during voluntary contraction and many deformed long-duration polyphasic motor unit potentials in both upper extremities, lower extremities, and abdominal muscles in this patient. So basically, as they described, the report was consistent with lower motor neuron loss without sensory involvement and diffuse denervation, reinnervation process. And they even described very specifically mentioned split hand and split leg sign on the right side in this patient. So the final diagnosis that, oh yeah, I can give you time to discuss.
No, yeah. I mean, maybe Rahul, you can share your thoughts and then hand the mic to Lyra. I'm just amazed.
Yeah, I mean, thank you so much, Shira, for providing this information. I mean, honestly, I never read any EMG or NCS report, to be honest. But I mean, the sensation is normal, reduced compound muscle action potential, and element loss without, I mean, I don't know if this is a consequence of muscle loss or still there is some brewing neurological process. I think Austin just put in the chat. Is it something to do with that? I don't know. I don't know, Rabi. I think it's kind of knowledge gap here again for me. Yeah. What do
Yeah.
you think?
Rahul, yeah, I'm no expert in the interpretation of EMG either, but I think it goes to show you its value add isn't just to localize, which it does here, but it also allows you to understand diseases of subclinical involvement. So we were representing the problem incorrectly, ultimately, by saying that the arms are spared. They are not. And it goes to show you that patient's reserve can sometimes camouflage weakness. And so when you start to say that the patient's arms are involved, it becomes a very, very fundamentally very different problem. Um, and so I just wanted to share with you, actually, maybe I don't think I'll skip over that, but yeah, I think that um, the additional value of the EMG is to both localize the lesion and also to help you understand previous sites of subclinical involvement. And I think um, the EMG is essentially diagnostic of a condition that I think maybe we can learn from Lyra. Yeah, Mike too, Lyra.
Yeah, so the final diagnosis in this case was unfortunately ALS, specifically the progressive muscular atrophy subtype, because of profoundly significant lower motor neuron features rather than upper motor neuron features. And basically what I was taught is it's basically a working diagnosis, not a final diagnosis, because we can diagnose ALS by biopsy or presenting some test. So it's actually this form that progressive muscular atrophy subtypes is also very prone to misdiagnosis. And the most common mimics would be the multifocal motor neuropathy. But the ENG and NCS in this patient weren't really consistent with this diagnosis, but they still decided to send the anti-GM1 antibodies, which are characteristic for this neuropathy, and they were negative. And another mimic would be myositis. And they also actually pursued muscle biopsy that showed no active inflammation, no necrosis, and just atrophy. So he's under the care of neurology now, and I think they're going to be evaluating him regularly, not so for the progression of disease, but also for the appearance of any extra ALS features that could potentially clue them into the potential misdiagnosis in this patient. Yeah.
There's so many reflections to have, and I'm so glad Vale is here, and then we have Manaswini doing the teaching points for the love of neurology. But Rahul, what are your reflections on this case?
I mean, again, thank you so much, Lira, for presenting this case. I mean, I was not even considering ALS in my radar, but this case really give me a chance to consider other motor neuron diseases like ALS, and it could cause a predominant, because my understanding of ALS was completely different, and what I'm seeing is completely different here. I think this definitely is a huge learning for me today in learning more about the ALS and identifying the true problem, and definitely how EMG and nerve conduction studies are helpful in narrowing a DDX. And kudos to you. And yeah, it's a pleasure always, Rabi, to discussing with you. And Lira, you outlined the case, fantastic. And we went from a claudication now with the ALS. That was fantastic. Yeah, thank you so much.
Yeah, I shared that sentiment. It was such a pleasure to discuss with you today. And Lyra, I think the way you did presented this case is really, really incredibly rich. I think the fact that you choose to use the EMG to reveal the diagnosis also illustrates just how difficult it is to suspect this condition before this test, and really illustrates just the importance of the EMG in a case like this. Um, and ultimately, when you're trying to localize a neurological condition, the physical exam has tremendous power. But ultimately, in cases like this, acknowledging the difficulties and the ambiguities is really, really important. And ultimately, I think my ultimate takeaway is one, the power of the EMG, which I think Lyra emphatically demonstrated by sharing and by how she revealed this case. But also, I think when people are profoundly weak, severely so, the ability to localize the source of their weakness on exam diminishes. The features that we use, especially the reflexes, uh, mitigate in their value. And like I shared with you, the fact that we can no longer use his reflexes to study where his lesion is makes it exceptionally difficult. And also, I think you're learning that proximal predominance does not equal myopathy. It prioritizes a myopathy, but is actually a feature of neuromuscular junction disorders, very commonly, including myasthenia and Lambert-Eaton. And this case is a reminder that about 10 to 15% of patients with ALS will also present with proximal predominant weakness. So a lot of things to reflect on. There's so much learning. Very gratitude to both of you for an awesome hour, and equally thrilled that we get to sit back and learn from Manaswini about what she took away from the session. Mike to you.
Amazing case, Lira, and wonderful discussion, Rahul. So much to learn. So, in this, some of the teaching points that I'd like to share is we were trying to solve a subacute to chronic, severely progressive, isolated proximal muscle predominant painful disease, which eventually progressed to involve the upper limbs as well. And we see that the decreased reflexes mandates disease in PNS, but the exception could be acute spinal cord disease, which was not seen here. And the proximal predominance, which might include the muscle, NMJ, plexopathy, neuropathy, and the lab signatures and the profound weakness of this patient could skew the localization. And the hyperreflexia was cluing in the nerve, but the disproportionate drop in the reflexes compared to the weakness could also clue in severe muscular involvement. And element denervation with the split hand sign seen in this patient could indicate motor neuron disease. And the labs were interesting. So Dr. Rabih shared an analogy where Q waves and troponin seen after MI, and in this similar situation where AST elevated more than ALT in this patient, which could indicate rhabdomyolysis. And the paradox seen here was there was normal albumin in spite of severe weight loss, which indicated the extent of inflammation. And EMG could help localize the issue and acknowledge the ambiguity of the exam, especially since this patient had profound weakness. And we were considering the possibility of necrotizing myopathy because of statin, but decreased finger flexor involvement and upper limb involvement deviated us away from it. And it could have been inclusion body myositis, where anti-cytosolic 5 nucleotidase antibody has high specificity and poor sensitivity, or it could be a rare hereditary or genetic disease or overlap syndromes or paraneoplastic. But in this case, the involvement of upper and lower limb, and with the help of biopsy and EMG, we were able to identify ALS, although it's something that cannot be definitively diagnosed. These were some of the teaching points.
Absolutely super, Masmi. I love that you crystallized the key elements along the way. I think this case could have been overwhelming with the amount of learning that you had. I just wanted to share one other reflection that I had too, briefly, because I think it's important enough to put out there, which is that the EMG also showed evidence of asymmetric involvement. If I'm not mistaken, there the right was more affected than the left, or vice versa. And I think it goes to show you yet another downside of when somebody's severely weak. When somebody's severely weak, your ability to use the reflexes clue is gone, and your ability to use asymmetry is also gone. And so I would imagine that if you had met this patient at the beginning of his disease process, based on at least his EMG when he was less weak, you probably would have seen disproportional hyporeflexia, and you probably would have seen asymmetry. And areflexia, disproportionate loss of reflexes and asymmetry are powerful, powerful clues to the presence of ALS, as are some of the clues that Vale mentioned about the effects on the intrinsic hand muscles, which when somebody is cachectic and frail and has a low creatinine, you can easily miss out on how much muscle mass they've lost. It's disproportional muscle mass they've lost in their thenar eminence or hypothenar eminence. So there's so much that this case can prompt you to reflect on, and so I thank all of you for an absolutely awesome hour or so. All right, have a great day, everyone.